Welcome everybody to the TikTok webinar today. I'm going to give just another minute or so to let folks get situated. All right, I think we'll get started so we can get the most out of our time with Dr. Gomi today. Thank you everybody for joining our TikTok webinar today. We are offering nursing contact hours after each of these. There's a total of 10 sessions in this series. These sessions are also being recorded and are available on our Mountain Pacific website. The next session after this one today will be on March 10th at 3 o'clock Mountain Time. There will be polling questions and that we will bring up during the webinar, as well as a link to the evaluation will be placed in the chat towards the end of the webinar. And you can see now on your screen there, hopefully that there is a polling question asking your credentials. I see that folks are filling that out. Thank you. You will have the ability to unmute yourself, but please keep yourself muted while the presenters are speaking. And we want this to be interactive, so there will be plenty of time for questions and answers and discussion. Now, I would like to introduce our speakers. We have two speakers that have been part of this webinar series. Dr. Eric Arzubi, he co-founded this Frontier Psychiatry in 2019 to introduce an accelerated, more aggressive response to Montana's growing mental health crisis. He served as chair of psychiatry at the Billings Clinic for 5 years, during which time he led the creation of Montana's first psychiatry residency program and Montana's first empath unit for emergency psychiatric care. Before moving to Montana in 2013, Dr. Arzubi spent 10 years at the Yale School of Medicine, where he earned his MD and completed postgraduate training in general psychiatry and child adolescent psychiatry. And also joining us today is Dr. Gomi. He holds a Bachelor's of Science in Computer Engineering from Rensselaer Polytechnic Institute, an MSE in Biomedical Engineering from Johns Hopkins University, and an MD from the University of Massachusetts. He completed a residency in psychiatry and a fellowship in movement disorders and behavioral neurology at the University of Washington. He currently practices neuropsychiatry with a focus on cognitive, memory, and movement disorders. He is also active in engineering and clinic research, focusing on using advanced technology such as voice recognition to track and monitor treatment of neuropsychiatric diseases such as depression, schizophrenia, Alzheimer's, and Parkinson's disease. Thank you both, and I'll now open it up to you for you to share your screen and start today's webinar.
Thanks, everyone. Man, I never thought I would get tired of hearing my introduction, but it feels like I'm watching Netflix and I just want to skip intro.
And I said Rensselaer, correct, didn't I? I've been practicing all morning.
Rensselaer. It's easier than making it. Rensselaer. Let me share my screen. Yeah, we'll work on some functionality for everyone so you guys can hit the skip intro button next time. So let's do this. Cool. Everyone can see my screen, hopefully. Nice.
Yeah.
So, session 8 out of 10. We are nearing the end, ladies and gentlemen. We have next month, we have 2 more talks and then that's it. Jill, can I mention the next series coming up, or is that still secret?
No, please do.
Cool.
Good idea.
So then, and I mentioned Dr. Seiss here at the bottom of my slide. Excuse me. He will be kicking off the next series of talks in a series focused on addiction medicine, addiction psychiatry, co-occurring disorders, and so on. So That'll be a great series we'll be tuning in for. So we're going to keep the momentum going and try to keep the series alive, and we'll have more announcements about that coming up soon. So talk 8, we're focused on psychopharmacology. No new disclosures from me. And you can see here we're at 8 out of 10 on our series. So before we jump into psychopharm, we'll do our usual weekly run through. I think we're getting more and more comfortable with this each week. So each week I want to invite others to also jump in. Can someone from the audience share what they learned, what in terms of what is their motivation for being here and being interested in trauma-informed care, and B, if you learned anything about new perspectives on adverse childhood experiences or different types of trauma. Someone jump in and share what your thoughts. Pull up, yeah.
My motivation is that it will help us provide a better quality of life for our residents.
Wonderful. Joanne, what makes you think that this will provide better quality of life?
Well, I've seen usage of a lot of different psychotropic meds in the long-term care setting, and many times it wasn't the best result.
Got it. Yep. Wonderful. What is, Joanne, if you don't mind, let me pick on you one more time. Where do you see, what's your sort of, I guess, the way you think about trauma-informed care and how it might connect to care that you're providing in the nursing home?
I think it certainly helps us individualize treatment based on several different factors, not just the fact that somebody's old and has dementia, but why are those behaviors happening and what is the best medicine, if any, for that particular individual. And also helping our staff maybe approach and interact with each individual person based on their past as well.
Thank you, Joanne. Yeah, couldn't have said it better myself. That's really why we're here. And really my goal is to just offer various perspectives, all with that foundation of trauma-informed care. So when we're talking about today, psychopharmacology, really just talking about, well, how do we look at medications a little bit differently than maybe we traditionally have? We, recapping a few more slides, we talked about our work in Lewistown, which lends itself actually a little more to the psychopharm topic, because we were really focused on reducing medications for them and doing these gradual dose reductions, which the lingo calls it. And really that's all about respecting patients' autonomy and reducing side effects. And so that the underlying driver is as a human driver, not to mention physiologically less side effects, but we then just use this marker. I mean, sometimes the subjective experiences is harder to track, but it's easier to track, like number of medications. So we always think about this in the quality improvement world, think about how you can track something, and you might have to use something that's not a perfect estimate, not a great surrogate, but in this case, we used a surrogate, so it's not perfect. We also talked about loneliness a few weeks ago and the impact, pointing out that it has the same or more impact than many of the traditional health factors we think about, like smoking and diet. And so we talked about, in each talk, we tried to focus on some tools. So tools here in the bottom left in terms of what you can do. So you can think about it, even since this original talk, have you tried any of these methods? Has anyone tried any of these, or has anyone not tried any but want to? Did anybody have any experiences to share? Has anyone tried using name tags or getting video calls set up for people, doing any like online religious services for residents? Anybody have a quick anecdote?
This is Sarah. I'm sitting in with Casey for the meeting.
Casey, this doesn't get you out of participating. I don't know if this is.
You actually had to step out for a minute, so I am actually her fill-in right now too. But I just going down the list, I can see that we have used the realistic toy animals for our residents.
Wonderful. So that's huge. Did you see, Sarah, did you appreciate any impact from that, or did you
Absolutely. I mean, it really does work. You know, it's definitely a comfort to them. They really, it is a very positive thing. We've used them with quite a few of our residents over here.
And so what Sarah's pointing out is, these are all ways to increase the sort of humanity, if you will, of being in any facility. And it really, even at being at home right now during COVID, right? We're all experiencing this to a degree. But that's what all this has in common, is helping you connect with the outside world, whether it's with each other within the facility or, animals, other things that give us that link to nature. So those are kind of the underlying drivers that help with loneliness. We also jumped into in a big theme with the psychopharmacology, because a lot of the drivers of medications has to do with a lot of people with dementia and some of the resulting issues that happen because of the dementia, and some of the actions that might come about by someone because they have a neurodegeneration. So we talked about how dementia is an umbrella term, right? It's kind of encompassing all kinds of different diseases, all leading to this common pathway of neurodegeneration and functional loss. And what we're going to see, the rule, not the exception, is neuropsychiatric treatments that neuropsychiatric symptoms, that come along with that. So things like anxiety, severe anxiety, feeling agitated, pacing, other types of things us as humans we will do when our brains are breaking down simply to try to feel better, or because we're not processing stimuli as well. So we're feeling paranoid or we're having psychosis. Remember, when we're working with patients with dementia, we're not going to call it schizophrenia necessarily or another primary psychiatric disorder. At the point that they have dementia, they have neurodegeneration that's been demonstrated. That really, in almost all cases, explains everything we're seeing. So it's not that we need to say that there's a separate psychiatric issue going on. It's things like Alzheimer's very commonly cause psychosis, delusions, agitation, anxiety, apathy. Those are a little bit separate. So we kind of have to change our hats a little bit and think about the behavioral health a little bit separately. Not to say, but you still have all those same symptoms, same experiences. Remember normal aging, as we're talking to each other, our family members and our patients, there's some decline in visual spatial function and speed, processing speed. So that's normal, have a little decline. We can reassure each other that that's probably getting older. The key point being, right, no change in function. You're still paying your bills, you're still cooking, you're still driving, all those things. Verbal ability, actual calculations, mathematical ability, memory, things like that really shouldn't change with age. So if that's noticeably different to the point where you're having trouble, you're having to use, different systems or reminders or tools, then that's something to think about. Keep in mind, there's lots of other reasons. It doesn't mean it's dementia, right? There's lots of reasons, like a poor night's sleep can have impact on these domains. More and more, we're hearing about different abilities to identify dementia early. So that was one thing we talked about, was moving from the clinical interview, us just our gut feeling when we're talking to somebody as we get to know them and having a good idea of where their brain is. But now we're getting tools that are becoming more and more available. We're working on making these more available in rural areas, especially in Montana, Alaska, Hawaii, Wyoming. We are working on, for example, mobile MRIs. A wonderful group, Monida Health Network, has organized mobile MRIs. So we're trying to figure out how to bring these to you, right? We're not expecting you to send someone really, really far to get their spinal tap and their spinal fluid test, but these are the practical things we're trying to bring to everyone on this call. And then really my big soapbox for dementia, right, is the importance of the diagnosis really comes in when it has to do with communicating with family members, because they really appreciate, both the patient and their family members really appreciate having clarity, having something to point to. It also helps them with resources and reading and knowing what to do, how to plan for the future. Research is a big one for me. I actively participate in research, but finding patients and identifying them accurately so that they can participate. And research in itself is therapeutic. The people that participate tend to really like it and also appreciate the impact that they're having on others down the road. I mean, they're helping, future people. And so it's therapeutic in itself. So lots of reasons, and it really helps us, even in the nursing home setting. If I tell you someone has Lewy body dementia versus Alzheimer's dementia, that's a pretty different thing. That helps you be much more prepared and also understand some of what you might see through a different lens. So someone with Lewy body who has a lot of anxiety, really severe anxiety, and then might have a lot of visual hallucinations, that's going to really help put it into perspective and also keep our wits about us as we address it, versus someone with Alzheimer's where visual hallucinations would be pretty uncommon. So that kind of leads us down a different road. And they still might have anxiety, might have depression, but the sort of those positive symptom psychosis, like a visual hallucination, auditory hallucination, those are a little less common. So it really helps us kind of target treatment and know what we're dealing with. Any questions? And really, strengths-based approach was one of the kind of points to hammer home here. And this is really fundamental to the trauma-informed care, right? Because not only does trauma increase, as you can see here, traumatic brain injury and even just early childhood trauma will increase your risk of various health issues, which then, of course, increase your risk of dementia. But look how many modifiable risk factors there are on this graph. These are all areas we can help people even now. It's never too late. I mean, even you have an 80-year-old who's still not wearing their hearing aids, feeling depressed, isolated. Absolutely, that's why we're here. We can have a positive impact, and you will improve not just their quality of life, but their longevity too. And that's something we know. So this is something we really got to hammer in and keep in mind that the trauma focus really helps us take that perspective of why someone might be looking the way they do all these years later. It might be tied to something decades old, but it really helps us focus on prevention and treatment. Oh, good. Casey's back. Hey, Casey. Can't wait for you to participate. Thanks. Got to give Casey a hard time. I've been trying to get her to participate one of these days. Prevention and interventions. We talked about, just to give some inspiration, for all of you. Really, if you guys kind of go back and try one thing from this, that's a win. We want you, and with them in mind that these are all based with this sort of trauma-informed care focus. But whether today's focus on medications, whether there's a positive impact from that, but just having any kind of intervention in someone's life in any of these ways will have a positive impact on their memory, their cognition, and their quality of life. The finger study, which is something I bring up often, is just a good example of bringing some science to this, where they actually did show demonstration of improvement in cognition by using an intervention that focused purely on nutrition, exercise, cognitive training, and things like that, things we can all do. We spent a session talking about delirium. This is also very fundamentally tied to the topic today of pharmacology, in that really orienting us all, right? Delirium, is something that disturbs our attention and awareness. So, the person's having a much harder time paying attention. They may not know where they are. They may be disoriented. They tend to have this come on quickly. So they might wake up with it, or they might have it that same day. That's going to catch your eye. It's not a chronic or gradual thing. They have one disturbance in cognition. So meaning like their executive function's messed up, their memory's messed up, something else is going on. Maybe they have visual hallucinations. Maybe they have other types of psychosis. And that's when you see this delirium, that's when we're thinking about what's causing it. What's the medical underlying cause? Do they have a UTI? Do they have something that we need to bring attention to? It's critical because it's often not the medical providers that catch the delirium. It's often, right, the people that are seeing patients day to day, because you all know the patients best. So you'll know if somebody is not in the normal sorts. I mean, when I see someone, let's say once a month, and I'm just meeting them for the first time, they could be delirious. I mean, yes, with a good thorough interview, I'll probably uncover that, but really just kind of right off the bat, and especially in their facility setting, we may completely miss it. So this is very much a team effort. The delirium piece is extremely important. to think of as a team. And the content of people's delirium, again, is going to be determined by their previous life experiences. So someone with different types of, let's say, a childhood trauma may have different types of delirium that pop up. Maybe when they're delirious, they really focus on a kind of a memory from childhood, and it comes out in that way. They have visual hallucinations or delusions or things that are really focused with that content. So that's how everyone's looks different, but that's why it's happening. And it kind of motivates us to then take extra care when we approach that person, you know, and be really careful. Because even though they're delirious, you know, it's an experience, it's traumatizing. And we talked about risk factors for delirium, and one of the focus, that's why today's we're talking about pharmacology, psychopharmacology, because polypharmacy is one of the most common drivers of delirium. You know, too many medications, side effects, interactions, things like that. Delirium and dementia tend to go hand in hand. So the risk of delirium is much higher if you have dementia. And so we can all get delirious, keep in mind, you don't have to have dementia to have delirium, meaning if I have surgery right now and then I don't sleep for 3 days, I probably will be delirious. And many of us maybe had some temporary delirium. Maybe you all can remember a time in your life when you didn't sleep for a few days, or you just had like, I don't know, 20 cups of coffee or Coca-Colas and that kind of stuff. Something that really threw you off, or you were sick, you know, you were infected, maybe you had COVID this year and you were delirious. And you remember feeling like, where am I? What's going on? Feeling terrified. Those are unfortunately things that many of us, if not all of us, will experience at some point. And so the risk factor for delirium, these interventions we talked about, such as like the stuffed animals, orienting, calendars, clocks, helping people sleep during night and awake during the day. So making sure there's like lights on during the day. If it's really dark or it's rainy, helping leave the lights on, having those sun lamps. Those are all improve their medical outcomes because it reduces the risk of delirium. So keep that in mind too. I mean, there's so many positive impacts from the work we've been talking about. Since last couple of weeks, has anyone seen any delirium come up in themselves or in patients? Anyone? Someone's had to have seen delirium in the last few weeks. Or maybe you found out after the fact and then realized it was delirium. Someone give me an example. Dun, dun, dun. I'm going to start calling out names. I'm just going to be mean. Amanda, do you have an example? So we got Amanda Ferguson, Amanda Wright. We got two Amandas. Either Amanda. Kathy Gross, Sherry Dix, Colleen Hogan. Does anyone have a microphone? They can say something. We got a Colleen Sperry, Corlin Simmons, or Simon, sorry.
There's one in the chat.
Ooh, oh, sorry, I missed the chat. Elizabeth, nice redirect, Elizabeth. I like your style. We have instituted several of these options. COVID is missing outside the box. Great. Our facility over time actually did. Each one is. I see. Is there a patient suddenly and ongoing experiencing delusions? So Zoom one-on-one with the priest, then service and holy water. Since she found strength and faith in sisterhood, always picked up the water when in bad times. It soothed. She did need antipsychotics, but it helped until psych. That's wonderful. That's a great example. And people, it's so funny. It's when I teach younger folks too. You know, I did a teaching session for a large group of high school kids recently, and it's funny, they were all much more comfortable with the chat too. It's all very similar. Okay. No one with any signs of delirium. Oh, that's a good thing. I mean, and possibly maybe that it helps because right now maybe there's less illnesses, you know, going around because we're being so careful and people are sticking to their schedules a lot better. So overall, I'm not surprised. I mean, delirium rates, I would imagine, are less. And we talked a little bit about this in terms of how to help it. And we'll touch on delirium with the psychopharmacology information today. We hopefully at this point, people feel comfortable at least getting a sense of delirium and assessing for it. You know, whether you even do something simple like ask somebody what they ate for breakfast or walk you through earlier in the day, spelling world backwards, doing some basic, you know, hey, count backwards by 3 from 100. You know, even if you do that, you know, again, these are not things that have to be done by a medical provider. These are things that all of us can do. And that gives us a really valuable piece of information. And that can be enough to trigger something like a urine test. I mean, those are all things should have low thresholds. There's no reason to be too conservative about that. Okay, great. Thank you guys for those responses. And then we spent a couple weeks focused on these behavioral emergencies with this sort of understanding that by behavior, we're trying to give it context in the setting of trauma-informed care. So we don't want to be in a situation where we're referring to anyone as, oh, they had some bad behavior. We want to describe it and be really clear and saying, you know, Mr. Jones, when I approached him to help him go to the bathroom, he became upset and he tried to push me away, which, well, makes kind of, could make perfect sense. So, you see when you bring language to it and when we talk about it in specific terms, it all of a sudden changes the perspective, right? And it puts us on a different path. So we're not just jumping to, oh my goodness, let's, there's no reason to panic. It's really more having a discussion. And then really it helps us figure out why and how to address it. So we talked about behavioral emergencies. Oops, sorry. And then both preventing, but also how to manage them. And so preventing, right? It's really all about, and I've mentioned this in a later slide too, just think about how you want to be approached. If you're feeling really upset, you don't have to be in a nursing home, right? Like if something happened, you have bad news, how do you want to be approached? So, there are things that are universal for humans, for those of us that are on this call, things like being validating, listening and being reassuring. Those are things that we all would like to have. And so we want to kind of be careful too, because sometimes we're working with someone, we're having a long day, it's really, really busy. I've definitely lost my patience. It can happen. And you know what? It's okay also when that happens, because we can always come back and apologize or, restart. So we're not looking for perfection here. We're just looking for ability to communicate, insight, and awareness. That's really what we're looking for. It's not, oh God, I was a little impatient with that person. That's okay. That happens. But saying it out loud, talking about it, that really, I think, makes a difference for people, and it really helps people appreciate the communication. And so here, in terms of prevention, you can see some of the modifiable risk factors that really tend to predispose to people having a lot of anxiety or anger or emotions that can get out of control. And they have a hard time, regulating themselves. Substance use disorder is the standout, the single most common coincident factor with these sort of quote unquote behavioral emergencies. So episodes where someone is at risk of harm to themselves or others because it's escalated to that degree. And so I'm sure we can all think of times in a work setting where we've seen, someone whether actively on a substance or withdrawing, for obvious reasons, really raises the risk for that risk of harm. So it's great that we're going to have a series taught by Dr. Seiss coming up to focus on the substance use in co-occurring disorders, because as we know, that's such a common issue for us. And then in terms of the management, really not just, how would you like to be approached, but having a very formal and organized approach with staff. We don't want to overwhelm people. It ideally will be someone the person's familiar with. There should be a leader. There should be very clear communication. So what I've seen happen many times in a facility setting is, when something happens that catches a lot of people's attention, it's very tempting to a crowd starts to form, multiple people, and whoever needs to, but someone needs to be identified very quickly and take the lead with communicating. So even if you can't prevent the crowd from forming, which, will happen, you're the focus of attention. And so you can be the communication for that person and really lead the way and really stand out to kind of give them something to really focus on, rather than being intimidated or just afraid because there's so many people involved. So as much as possible, trying to limit the number of people while maintaining safety. And really tying this back to the trauma-informed care piece is, if someone's having trouble regulating their emotion and having resulting actions that may be at risk of harm to themselves or others, again, just a simple pause of wondering, why is that happening? Is that related to something previous in life? We'll immediately change our stance. It brings in empathy, which is in this day and age, it's just because we're so busy, there's so much to do, so much technology involved, it's easy to sort of miss that. And so just think of it that way. We'll sort of naturally bring out the empathy, helps us approach people. Does anyone have any examples? And feel free to put in the chat, because we all know what's going to happen when I call out your names. Anybody have any examples of incidents at all? Could have been minor, doesn't have to be a full-blown emergency, but any examples of any issues with people being really, really scared or acting out, things like that, that was difficult to understand or that was able to be managed in the last couple of weeks? This is my test to see if you guys are paying attention.
Hi, this is Julie and Gillette, and we currently have a female resident who diagnosis is really failure to thrive, and she is yelling constantly for help. Even if you are sitting with her at her side, she knows you're there. She appears to be alert and oriented. When you ask her why she's yelling, she says, because it's the only way I can get what I want. It's constant, and there is no redirection. There's no comforting her. She knows she's doing it. She can tell you she's doing it, but it doesn't stop.
Interesting. So am I right to say that there hasn't really been a solution found at this point?
Correct.
And is this yelling or attention seeking behavior, is this sort of happening throughout, like all day long? Is it?
Yep, and through the night when she's awake.
Mm-hmm.
She does it when staff are with her. Husband reports she was doing it at home when he would leave the room. He is allowed to spend a little bit of time with her now here, and she's doing it even when he's in the room.
Mm. So even when he's in the room, I mean, do we think this is related to a dementia or like a brain disease? Like, do we know of, or?
I don't believe so. It comes across to me more as a learned behavior of some kind, especially because she can say she's doing it for a reason.
Mm-hmm. And then has there been any clarity or insight about, is she terrified of being left alone? Is there fear behind it? Is there something else?
There doesn't seem to be. She wants to go home, of course. She's able to identify what she means by home. She denies any kind of spiritual distress.
Okay. Absent, any organic causes where it's a dementia or other brain injury, intellectual disability, things like that. And absent, of course, of course, there's likely something learned in there from over the years and something driving it, maybe that has provoking a fear response. But if it's purely the learned behavior piece of it, I wonder about, and I don't know, depending on the facility, how possible this is, but trying to provide, it's sort of like a DBT approach of providing sort of a structured response. So saying, okay, looking at the schedule and saying, okay, you know what, the way she's yelling, we're going in there 20 times a day. So let me just go in with her and say, and you can try this and say, listen, it looks like we're visiting you X number of times a day. We'll come in. How about we'll have someone check on you every 30 minutes, every hour. Whatever makes sense that approximates what it is now. And we'll do that on schedule if you don't yell. And then, if you do yell, we're going to space it out. Then, we may, to provide some sort of reinforcement, positive reinforcement for the not yelling part. and maybe just removal of a positive reinforcement rather than punishment, just removal. So I don't know how possible that is. I mean, I've seen that done in some facilities, like I've seen it in the inpatient unit, but that's, when they have private room and they can kind of yell a little bit and you don't have to worry about other people being affected. So I don't know if that's potentially helpful.
Yeah, actually, setting up a time that staff are consistently going in, I think might be a good idea. So she at least knows, since I don't think we're really dealing with a dementia type of foundation here. I think if she knows that she'll get what she needs every number of times. So.
And you can even, make sure she can see the clock and say, see, every time the hand is, on one of these, we'll come in now, and we'll make a deal. We'll do that if, you don't yell out for help. So that might help just separate it. That'd be an interesting data point to see if that's helpful.
Okay.
Anyone else? So as we jump into the psychopharm piece, we ended the managing behavioral emergencies with this kind of note about, if medications are used, being sedated or restrained chemically, that can be highly memorable and not in a good way. So we want to be very, very careful when we do use medications. If someone's going to feel sedated, we really got to make sure they feel extremely safe and protected and, not vulnerable, which could be very, very hard. So transitioning into psychopharm, what does this have to do with me? I'm not a prescriber. Well, too bad. We all have to pay attention. So the point of this is we all are stakeholders here, right? We all have skin in the game. So I'm not asking you to be a expert, but there are absolutely some core fundamentals that we can all chip in with. So real quick poll, do you feel comfortable identifying common medications to be avoided in older folks? Go ahead and answer. Like when you see what a medication a patient's getting, or you have a patient ask you a question, do you feel comfortable identifying some of these? Awesome. Thank you for responding. We'll see when the results pop up. One of the nice, kind of a really good reference tool, and I'll share with the slides when we post this after this, but the Beers criteria, this came out a long time ago. I want to say in the very early 90s, even now, it's been a while. It's named after the person who came up with this, but it's gone through several revisions. The American Geriatric Society manages it, and 2019 was the last set of revisions. And so these are just some bullet points from what they revised, but the Beers actually is a list of medications to be avoided when you get older. Now, keep in mind, it's not black and white, right? Like some medications, you have to weigh the risks and benefits, but I find it very helpful because it provides a list that in general, you can kind of think, okay, maybe this is something to be avoided. So that's something we can all use, we can all refer to, and then it can strike a conversation, maybe with the pharmacist, maybe with the provider, and say, hey, I noticed patients on this medication, like, are there other options maybe? Because often there are. And you can see things that, we learned that I also very much use in practice because I see a lot of patients with Parkinson's disease, right? And that also stretches out to, here we go. Let's look at the answer here. So for number one, oh, good. About half of you said yes. And then kind of the rest were split among no, not sure. Great. Thank you. Wonderful. Thanks for putting that up. So we'll see if we can increase that number today over the next few minutes. So avoiding most antipsychotics in people with Parkinson's disease. The challenge is, again, if we don't know someone has Lewy body dementia or Parkinson's dementia, and we're thinking, oh, they're just acting out, let me give them my usual, Haldol or Zyprexa. Most often that will backfire. That absolutely can make things worse, and it usually does. Because of that Lewy body pathology, the alpha-synuclein protein that's in the brain cells does not like dopamine blocking. So this is important reasons to kind of keep track of these things. There's also a point about avoiding rivaroxaban or dabigatran with older folks, just because they have high risk of bleeding, especially people with fall risk. As you get older, you often will age out of the benefits of blood thinners. because there's such a risk for falling and having a bleed. So we want to be reassessing that. Keep in mind, often our patients in the nursing home, I'll have patients who maybe had strokes earlier in life, but now are having dementia and they're really high risk for falling. We'll take them off aspirin even. We'll take them off blood thinners. But that takes somebody advocating and bringing it up, because, you know, if everything's kind of going, you're not going to know until they fall and they have a bleed, and then it's too late. But if someone's 90 years old and they're high fall risk, and you see that they have a blood thinner, there's a pretty good, that's a reasonable conversation to be had about should they be on that, because, you know, there's the risk gets higher with age. Avoiding tramadol with older folks, which we often do see because of the risk of low sodium. And that can be an issue because that will cause a lot of other issues. So the risk, again, starts to get older, is higher as you get older. And then avoiding prescribing opioids with benzos or gabapentin because of that respiratory depression. So we're thinking about sedatives. Let's move on. So here, let's throw up the second poll while I check into the chat. Please put in your questions in the chat as well as they come up. What is the most common medication you see patients for agitation or severe anxiety? Go ahead and you can type it into the chat. So please do that. You spend a couple minutes. And then Corlin, the gentleman you talked about, a large older gentleman with the diagnosis of autism, depending on how where on the spectrum of autism he is. What I've done in that situation, and I've found some benefit with, is, I don't know if, and you may have tried this already, but confronting them in a, again, warm way, but saying, wow, you know, what you just did, and describing the behavior very well. And making sure, I don't know, I really act like I show that I'm scared, and I explain why that was really scary for people around them, and that it's really, you know, scaring people and so on. And I've seen that really kind of snap people a little bit out of it, and just kind of, even with, you know, when they have autism. So that's something you might think about. It's kind of a counterintuitive at times, but I found that to be effective. Geodon and Seroquel, Risperdal, Ativan, Risperdal, Seroquel. Yep. So these are the most common. Very nice. Yep. These are extremely common. Xanax. Nice. Get the good stuff there, Gail. Good. Trazodone, Risperdal. Awesome. Thank you, Ativan. Okay. So I haven't seen any surprises yet, but I'll keep my eye on this. So Dr. Karen Duong, who works with us, is a geriatric psychiatrist, wonderful colleague. I'm actually going to share a tool with her, and I'm going to share this with you afterwards so you can keep this on you. But it's a really helpful tool for thinking about some of the medications. So I just want to kind of step through this together. She had support from the Veterans Administration, the VA hospital, to make this. And I find it very helpful. It's a really nice, handy kind of little pocket guide. And I will share this with folks afterwards. But again, initial step before we jump into medications, of course, is always identifying behavior symptoms, right? So like being specific. We don't want to say, oh, they have behavior, I'm going to give them Haldol. It's like Haldol PRN behavior. That's not a thing, right? You want to say they have so much anxiety that they're, you know, pulling their hair out. So you really want to be able to be very specific. And that way we can tie, if a medication is going to be used, it's less likely to be overused because it's tied to a very specific thing. So when you see a prescription come through, and if it's too general, you can also be an advocate and say, can you please write more specific parameters around this, right? Because I've been there, you know, 2 a.m, I get called, I'm like, Ativan, PRN, whatever. You know, it's tempting to sort of leave it open-ended. And so we have to be a little bit careful and try to put some parameters on it. You want to characterize those behavior symptoms, right? When did they start? It's going to help you identify delirium. Is this delirium? Because if it's delirium, I don't want to throw Ativan at it, right? I got to think about what's causing it. So contributing factors, right? And this is focused on, of course, veterans, but really this applies to anyone. I mean, we're all humans. This will apply for. So the great thing is take that preventative and management stance. So the non-pharmaceutical approaches first, right? Can I change something about the environment? Physical factors, is there an infection? Are they hungry? Are they constipated? Is there something I can help with the caregiver? These are all the questions asked before we go to medication, of course. In an ideal world, right? And granted, there's many limitations. There's many times we're not going to be able to go down the entire list, of course. We have staff limitations, time limitations, but thinking about a few of these will often de-escalate or address a concern without even needing to get to a medication. And so this is a nice, on this guide, this is a nice little reminder about where to look. And then here it is on that under substances, the use the beers criteria or the stop start, which is again, those same criteria I was mentioning, where you can have like a quick reference to substances, including medications that can often be detrimental or just harmful for older folks. And then there's some different reminders here of what you can do physically, psychiatrically, changes in the environment, and then caregiver, what the caregiver can do. And again, I'll be sharing this with you. So I'm going to jump into some specific medications. Again, not because you all need to become pharmacists or pharmacologists, but just some core things we can all pay attention to. So let's throw up this poll. If your patient can't sleep, what's the best option to provide them? Go ahead and answer this. And this is purposely left a little bit open-ended, meaning, as I like to have with my questions, you guys may be familiar by now, is I like to have some multiple correct answers. And so the melatonin, which is attracting a lot of correct answers, that's, in a way, you sort of can't go wrong with it. So I think it's a safe one. I mean, it's really not going to cause problems per se. However, I'll ask people, and whether you can unmute yourself or in the chat. Let me jump down. Actually, Gail, you mentioned sleep hygiene should be first. So that's, 5 of you so far have said CBTI. How many people, who knows what CBTI is? Can someone unmute and say it out loud or type it in the chat? I know someone knows. If you don't know, I'll jump in. Right, it's cognitive behavioral therapy for insomnia. That's right. So Gail, exactly. So sleep hygiene, and that includes a lot of sleep hygiene. So you're absolutely right. And I actually will say, and I tell this to my patients, and I have yet to be proved wrong. If you follow the cognitive behavioral therapy for insomnia rules to a T, I've never had anyone, and I stand by this, I've never had anyone not be able to stop their sleep meds. So I've been able to get every patient off of sleep meds by using CBTI. And for some people, they have to be much more strict, but just to point out that it is possible. If you're independent, you have control, and there's a lot of things obviously where we're assuming here, but the cognitive behavioral therapy piece, what's nice is, and this is actually another VA tool, is you can download, it's free and it's made by the VA. It's called CBTI Coach, which stands for the Cognitive Behavioral Therapy for Insomnia Coach. So CBTI Coach. Now you can get that on the App Store. It's not pretty because it's a VA app. It's not like a fancy, it's free, but it has all the content there. It's really nice. It has some meditations in there. It's got reminders. It's got a little sleep diary. I've never not been able to, again, it's very, very helpful. So with that understanding, and that really helps people when they have the ability to. Now we got someone in a facility, they maybe have dementia, there's other issues. The CBTI may not be as readily accessible. Melatonin, great point. What time do people see patients usually taking melatonin? Are you giving patients, is it after dinner? Is it right before bed? Jump in. Yeah, this week no one wants to say anything verbally. I think I scared everybody. After
We do
dinner.
it with the PM Med Pass, so at HS.
Okay, HS. So that's usually 8 or 9 o'clock?
At 9 o'clock for us, yep.
Okay. Nice. Shona says after dinner. Okay, supper. Yep. So these are the most common. Supper time or an hour before bedtime, right? Salhan, and then Amanda after dinner. Nice. Concepcion, around 8 or 9. Okay. So one thing to keep in mind, and this could be a little positive change, if someone's taking low dose melatonin to help them sleep, meaning 1, 2, 3 milligrams, lower dose, there's some weird reasoning as to why the milligrams are the way they are. Scientifically, actually, your receptors for melatonin in your brain actually are saturated at like 300 micrograms, so like 1/3 of a milligram, believe it or not. But for marketing and other reasons, they sell the much bigger doses, even though it's overkill. So really 1 milligram is even all people need for things like jet lag, for circadian rhythm issues, right? Now, if you're going to do it for circadian rhythm and just helping for like standard melatonin use, you want to give it after dinner, because you want to give it about 5 or 6 hours before bedtime. Because think of it this way, melatonin is the signal to your brain that the sun went down. When do you want the sun to go down? You don't want the sun to go down at 9 or 10 o'clock at night, right? You want it to go down around 5 or 6. That's because their circadian rhythm then triggers 5 hours later as they're supposed to be asleep. The only time you use it at bedtime is in people with Parkinson's, Lewy body dementia, or REM sleep behavior disorder. We use high dose melatonin at bedtime. That really helps with that. So be acting out their dreams. If people are acting out their dreams, we'll give 5, 10, 15, even 20 milligrams at bedtime. But keep that in mind. So you can kind of help advocate for people. Hey, if you're taking just 1, 2, 3 milligrams for general like sleep hygiene daily, very safe, do it at dinner time, if that's possible. If again, don't get mad at me about logistics. If it's logistically very hard, pretend I didn't tell you anything. But that will help. And then trazodone, and, I threw this out there because I always find it interesting. Trazodone is actually very safe and effective for sleep. It's an old antidepressant, very safe. We use it a lot in dementia because it's doesn't have a lot of side effects, a lot of issues. You always got to be a little bit careful with like any medication, fall risk and blood pressure. But I've used it so much, and it's so rare that I see that issue. So keep in mind that's a little bit of a step up. That's like, okay, then melatonin's not working, sleep hygiene's not working, then trazodone. Ativan and Benadryl are the no-nos. We really, in older folks, I will never give those. Benadryl, anticholinergic. So one big point to remember today, anything that's anticholinergic, which Benadryl is sort of like the thing. People forget, they're taking, I take Tylenol PM, Advil PM, NyQuil PM. Guess what? If it says PM, it has Benadryl in it. So nothing with PM, nothing with Benadryl in it, none of those. A lot of the bladder meds have Benadryl equivalents, things like that. Anything that dries you up. So if you take something to dry up your nausea, to dry up your bladder, right, it dries up your brain too. Think of it that way. So no anticholinergics. Thank you for that. Okay. So our last few minutes, let me just focus on pharmacological management. So we have kind of the big classes are antidepressants, antipsychotics. Those are the ones we see most often, right? There are these cognitive medications in the bottom left there. These are the only ones we have currently FDA approved for dementia, for Alzheimer's disease specifically, and then we use them for other types of dementia. Donepezil, galantamine, and rivastigmine, those are the same, they're the cousins, so they do the same things. So you'd only be on one of those. And then memantine is another cognitive med. So most people in the moderate or beyond stage of dementia will be on one of those first three, like donepezil and memantine. Okay, those are supposed to help with cognition. They're okay when you get old, but as you get much older, like once you're in the severe stage, you really start to question, medications in general. You don't, they're all, again, the risks really go up. So you might find it's time to take people off of those actually once they get much older or much more impaired. On the right there, the antidepressants. I'm sure you guys have seen all of these at this point. The things we use when we're younger and healthier are just not the same things we use when we're older. Again, because of that risk-benefit ratio changes. And when we introduce things like dementia, that will offer a totally different variable. So which one of these antidepressants, can people jump in, whether in chat or on audio? Which antidepressant seems to have the best evidence in Alzheimer's disease patients with depression or apathy? Which antidepressant? Take a guess if you can. It's a safe space, guys. More participation, the better. Casey, take a guess. This is the easiest contribution I'm going to have you make here. Take a guess. Casey? I can't hear you.
I put it in the chat. I put
Oh, you did? Okay. What did you put in the chat?
citalopram.
Nice. Where'd you learn that?
Sarah.
You, Sarah and I learned from you,
Nice.
or we were
Yeah, so
hoping.
Corlin, so yeah, sertraline tends to be used in geriatric psychiatry, commonly in dementia for whatever reason, and there's several studies showing this. It seems to not be placebo, but citalopram, that's the one that comes on. Escitalopram as the basically the exact same medication. It's very close, but citalopram helps with apathy. In fact, there's a trial, there's a multi-site national trial going right now to give citalopram a specific FDA indication for Alzheimer's. And also there's preliminary data that it helps with agitation as well. So fascinating, but for whatever reason, the Prozacs, the sertralines, all the other, they don't seem to be as helpful. I'm impressed. Look at how many people said citalopram. Way to go, you guys. So paroxetine, we don't use, right? Because when you look up the data, a lot of them say, oh, use paroxetine. That's because there was so much of it when studies were done in the 70s and 80s that a lot of them were like, oh, paroxetine is a helpful antidepressant. Yes, it is, but it's short acting. It's a pain in the butt to get off of. It's really nasty withdrawal. There's no reason. We have other medications to use. There's no reason to ever use paroxetine, really, especially in older folks. Trazodone's down here, really more with that sleep. It's not a great antidepressant. Venlafaxine, we avoid in older people. Again, blood pressure issues. It's also just painful to come off of. So I'd rather do it sooner rather than later. So really the ones I'll use, I'll see mirtazapine, trazodone, citalopram, and duloxetine. Bupropion occasionally for people that really need some extra energy. But the other is just harder to use in older age and harder to tolerate. Last question, and then before we wrap up with antipsychotics, what's the best antipsychotic for those with severe agitation or ongoing aggressive behavior with dementia, in those with dementia? Go ahead and put in your answers. Feel free to elaborate within the chat if you have anything to elaborate on. And a lot of people saying, so yeah, we got some Zyprexa, olanzapine, a lot of Seroquel, which, come on, people, answer more. We got way more people than are answering on the call. Throw in your answers. Come on, let's see who wins. Come on. 3, 2, 1. We're going for, it was almost a tie. Okay, so Seroquel and risperidone are very close. Yep, Haldol has kind of fallen more and more out of favor. We don't see that as much. Zyprexa for sure, we see sometimes. So remember, a lot of these more useful in younger or with primary psychiatric issues like bipolar 1 or schizophrenia from earlier in life. In dementia, the standout medication on this list is risperidone. And again, don't ask me why, but study after study, it's convincing. Risperidone seems to be the go-to. Seroquel doesn't seem to help with agitation and dementia. We use it all the time. Don't get me wrong. I still see it used. Data just doesn't seem to help. And so I tend to use, again, this is like last resort, right? Risperidone tends to be the go-to. Let's take a peek here. And again, I'll distribute this guide. And so here on the left, the antipsychotic medications, Abilify does have some good evidence. So it's the only one that's comparable to risperidone, but in older folks, we try to avoid it because it causes us akathisia. It causes that EPS, like Parkinsonism. It makes you kind of lock up. It's not as easy to work with. For whatever reason, risperidone doesn't do it as much. Of course, remember, LBD is Lewy body dementia. In that one in particular, we have to be really careful. And so that's the one time where we'll use quetiapine because it's a much gentler antipsychotic, so it's less likely to cause worsening of your Parkinson's or Parkinsonism. So keep in mind, antipsychotics, risperidone. If you see people on other stuff like Haldol, olanzapine, there's just, again, you might ask, like, hey, have we tried risperidone or something? You don't have to be a prescriber to ask these questions. It's helpful to prompt the conversation. Yeah, there might be cases where they say, yeah, we actually tried everything. This person, I've had patients that tried a bunch of stuff and they just, for whatever reason, olanzapine, but really across the board, anecdotally, I found that risperidone has been the most helpful. And then on the right here, additional medications. We've got some ones that kind of don't fit under like clearly under a specific category, but a lot of them are mood stabilizers or anti-epileptics like seizure medications. You know, it's also not as helpful. I really only see these, or I use these in my patients that have long-standing bipolar disorder, but unfortunately happen to get dementia as they get older. And I've had patients, I've been impressed, I mean, in their 70s, even 80s, where I'll try to take away one of these medications that they've been on for decades, and they start getting manic. It's fascinating, very unexpectedly, because they tends to calm with age. But the lorazepam, the other benzos down here, really has to be a really severe, rare, acute setting to use a benzo. Really, I generally just avoid it. Prazosin, very effective for sleep and nightmares. Also, a lot of these blood pressure medications like propranolol can be helpful for anxiety when your system gets really agitated. You know, you get like your high heart rate, you're sweaty. If you see people having like a big physical reaction to anxiety, one of the blood pressure medications might be really helpful. Any questions? I want to pause here for a second as we wrap up. I know we're just about out of time. Any questions in particular as we wrap up? Do you guys kind of seeing this? Do you feel a little more comfortable just sort of eyeballing a med list and just kind of being able to ask questions like, hey, this is anticholinergic. Can we switch to something else? Hey, you know, why is this person on so many benzos? Maybe we should kind of move towards, because if they need to be on a bunch of benzos, you know, then the question is maybe they can just be on a little scheduled risperidone. Jill posted the survey, please, in the chat. So make sure you fill out the survey for today before I forget. Any questions? I've seen a couple patients at Weston County with KC and folks, and just getting started there, but trying to help people transition off of some of the hypnotics, some of the benzos, and there are patients where we've used risperidone because they're really having a really hard time. On the larger dose of melatonin, should they be tapered off to lower dose? Can they change to lower dose right away? Oh, good question. You can, with melatonin, you can jump around. You can go switch right away. So, and that's okay. And again, the higher dose, it's just that it's not really necessary. The timing matters more really than the dose. But yeah, keep that in your back pocket. If people are acting out their dreams, not sleep talking, that's not REM sleep behavior. Sleepwalking, believe it or not, is not REM sleep behavior. Acting out your dreams, you know, like purposeful behavior. Sometimes their partner gets hit, sometimes they fall out of bed or smash something, that kind of stuff. The high dose melatonin is actually, it's amazing how well it works. Any other questions? This is the shyest you guys have been. I'm impressed. Yep, Gwen, I will forward that to the Mount Pacific folks, and we'll post it the same place the slides get posted. So I'll make sure we do that. So really, as you guys go back, just take a peek as a matter of exercise. Not to add, we're not trying to add stress or more stuff for you to do, but this is all things that kind of can become muscle memory. And just looking, hey, I caught a couple people that were on Benadryl and we got it stopped. Big win. That's avoiding long-term issues. I've had a number of patients come to my memory clinic when all I had to do was stop their Tylenol PM and their memory issue resolved. So those were easy fixes, but that happens pretty commonly. You guys are definitely welcome to go. I know we're over time, but I just wanted to, I'll stick around for a couple minutes. If anyone has questions or wants to speak privately, let me know. We want to make sure you guys feel comfortable with just some introductory medications. In the bottom right there, actually, we will use methylphenidate or other stimulants. I will use them in folks with dementia or without dementia, but older folks that are really having a hard time getting going in the day or just really having a hard time with apathy, and find benefit, because at that point it's really helpful for quality of life. And unless they have extensive vascular disease, like previous heart attacks, things like that, it's not necessarily high risk. citalopram, risperidone, trazodone, mirtazapine. Any other questions? Casey, are you raising your hand? It looks like you have a question. Okay. You guys, yeah, reach out if you need anything. I will get these slides posted. Oh, one other question, appetite. What's the question? Appetite, like does a medication make it worse or better? To increase appetite or lower appetite? To improve appetite. Yeah, if you're really needing help, medication-wise, mirtazapine's a pretty good go-to. It will improve your appetite. It can help with the sleep at night. So you just give it at night. It's an antidepressant, but it's a little more helpful, I think, for appetite and sleep. Also, if they happen to be on those antipsychotics, I mean, the average antipsychotic, you'll gain 7 to 10 pounds on in the first year, so for 6 months. So those don't do it in as healthy of a way. I mean, mirtazapine is more of an appetite stimulant, whereas the antipsychotics tend to just screw up your metabolism. So your cholesterol will also go up, your blood sugars will go up. So it's not a great way to gain weight. Yeah, the cannabinoids. It's interesting. We don't really prescribe it, I guess, with legalization in a lot of states, and actually just recently was legalized in Montana. It's been legalized in Washington for 4 years now, 5 years. So I just kind of give guidance for people. I don't prescribe it, just it's so accessible, but I will walk them through that. In general, you want to avoid THC, or you want to have like a 10-to-1 ratio of CBD to THC. So much, much more CBD. I actually have someone who sticks to CBD products in Montana, and is actually was recently released from prison. That's how we're seeing them. And it's coming up clean in their drug tests with their parole officer. So that was reassuring too. But yeah, higher CBD, lower THC. THC is just not going to help once you get older. It's the one that makes you feel goofy and get you like anxious or confused, that kind of stuff. But yeah, CBD is very helpful for anxiety, sleep, pain, those kinds of things. So I have a bunch of patients, many that I just tell them, with these guidance, I try to get them to not use THC or use very, very little of it. I also try to get them to use oral, like oil or edibles or stuff like that. So you're not smoking, and I'd prefer you don't smoke, just because it's not same as smoking cigarettes, but it's still not good for your lungs. But yeah, CBD specifically is helpful. And anywhere where it's legalized, you walk into a store and you tell them, hey, I need some CBD for my sleep, you'll get quite a nice little sales pitch. Any other questions? I'm impressed. It was all the way at the end that someone asked about weed. Right. Yeah. You don't need, in those states, you don't need a prescriber. Although I guess some states there's like medical cannabis, so you can get like a green card or whatever it is. But since I've been practicing, places I've been practicing, it's been legalized recreationally, so that hasn't even come up. All right, I'll let you guys go then, and I will get these slides posted. Thank you, Jill and everyone. Thanks so much, everyone. Yep, no, great questions, and a couple more sessions left, so come ready with questions next time too, please.
Thank you, Dr. Senigomi.
You're welcome.